The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to the December 2 Safe and Calm webinar. We hope you were all able to have a safe and restful holiday. This is, again, Deanna Mitchell with LeadingAge Michigan, and this morning we're going to focus on the many recent updates and some new guidance from MDHHS. Before we do start, however, I want to let everyone know that we will not be holding our Wednesday webinar next week on December 9th. That is the day that we're going to be celebrating our members, and especially our annual award winners. And Blake will be talking a bit more about that later in the presentation. So our agenda this morning starts with an update from Dalton, our Director for Public Policy, who will be providing an overview of Michigan lame duck issues. We will, as usual, look briefly at the Michigan numbers. They have improved slightly, at least since last week. And we will finish our updates that are mostly from MDHHS. The content, except for just a few programs and slides here and there, the content is really pertinent to all member types in general. So we will now turn the presentation over to Dalton.
Good morning, everyone, and I hope everyone's doing well and had a great Thanksgiving. Today we'll be talking about kind of what we expect to be watching for and what we'll be watching during lame duck, and also about an upcoming bill package that I saw was introduced yesterday that kind of codifies some of the executive orders that I know a lot of our members were able to take advantage of regarding the licensing and use of volunteers in long-term care settings. So let's start with what we're watching for in lame duck. I see one of the points got cut off on the bottom of the slide there, but I'll be able to address that. So as you know, if you've been on these calls, any time there'll be a new legislature coming up, which is the case now because of the elections, and the time before that, the last month of session after the election, before the new people come, is called lame duck. And this year, as happens every couple legislative cycles, all the bills are going to sunset. So all bills that have been introduced by this current legislative chamber will need to be reintroduced next year because they will sunset December 31st, and on January 1st, it'll be a fresh slate for the new legislature to start, and then the bills will need to be reintroduced if they're looking to pass. A couple things we're looking out for in lame duck and we'll be watching, because I know some of these are already up in committee. We do expect there to be some sort of a supplemental, kind of a closing of books / all business for the year. We will be on a call with the State Budget Director, Chris Clove, this afternoon, where we expect to get a little bit more detailed information on what the supplemental will entail. Right now, everyone's not expecting there to be any kind of funding increases or decreases, just because there's no money at the state to really go anywhere. So we just expect it to kind of be wrapping up the state's budget for the year. Also, a bill to establish legal immunity for healthcare providers, such that it's an exact copy of the one that was passed earlier in the year to cover kind of the first wave of the pandemic. That is making its way through, and the legislature is currently working with the governor to find a way to make the bill more palatable for her so that she'll sign it. Right now, she has signaled that she doesn't really want to sign an extension of the liability, but the legislature's working with her. And lastly, the one that kind of got cut off, there is that electronic monitoring bill for SNFs in committee this week, and then it will have to move to another committee if it passes out. It's in committee today. They don't expect it to pass the first committee today, but it is important to note that in our conversations with the bill sponsor, he has indicated that he will, if it doesn't get passed this year because of the time crunch, he will reintroduce it next year. And next year, he also plans to put in the process a bill to provide for electronic monitoring in AFCs and HFAs. So I am calling on all of you to, if you'd like to get involved in a work group, please let me know and email me. We'll talk about some of these issues because I don't think this electronic monitoring issue is going away anytime soon, even if it does get kind of meets the sunset date this year. So if you want to get involved with that work group, I'll also have an article in the upcoming newsletter. Please feel free to reach out to me. In a little bit more exciting news, the legislature let us know, and I saw the bills yesterday, so this is happening right now, that they're going to be codifying some of the executive orders, specifically some that long-term care facilities did enjoy. Some of the highlights of it include issuing temporary registrations for people to become certified nurse aides, even if that person has not completed the nurse aid training required by the Public Health Code. You can renew licenses for doctors, nurses, surgeons, pharmacists, and respiratory care workers, regardless of whether they have met the continuing education requirements during the time of the pandemic. It also would formally recognize the hours worked for employees with those licenses when responding to the coronavirus emergency as hours counted towards continuing education. And it would allow any individual who is a non-nurse aide, and there's some examples right there, to help feed or transport patients in accordance with their care plan and eliminate provisions that require a healthcare professional as a condition of licensure to renew a license or to register for a license, have them sit for an oral or written exam, get their fingerprinting done, or submit continuing education. So essentially, they're removing barriers to bring people into the workforce and allowing for some workforce flexibilities. And I'll have, since the bills were introduced last night, I'll have some more specific language for you in a future presentation. Back to the important date slide. Just want to highlight here 12/15/2020. You'll notice that the CRC and CRF application deadline was extended. I saw that Deanna had sent something out over our listserv, and I believe we included it in an LMI News member update. So just trying to spread the word on that.
Okay, well, thank you, Dalton. Moving forward with the Michigan situation update. Yesterday, the governor held a press conference and identified that there had been some slight improvement in overall caseload numbers. But she's going to wait to see the data over this next week to decide what to do about the current restrictions. She also stated that she had no preconceived ideas at this point, so she's going to depend specifically on the data, probably for the next 7 days. So as we look at our standard tracking data, you can see that the Michigan 7-day rolling average of new cases did start to decline this week, and almost every day over the past week. This data is through yesterday, December 1st, and so hopefully the numbers will remain low, although we do have the Thanksgiving holiday impact coming down the road as well. Unfortunately, though, the overall caseload is one of the few pieces of good news. In general, deaths are increasing, and there were a large number of deaths reported yesterday, and you can see a steep incline in the 7-day rolling average there. The state positivity rates, which, if testing numbers stay stable, will directly correlate with your caseload rate. And so you can see the positivity rates as of November 27th, and these are only updated weekly. So you can see that the positivity rates are stabilizing a bit, and hopefully this will hold in the near future. But again, we're also looking next week at the impact that Thanksgiving will have on these numbers. Starting on about day 10 after the holiday, we may expect to see a rise in these numbers. and that would start to occur over this upcoming weekend. Looking at the SNF resident caseload reporting, you can see that there was a significant incline over the past week. As of 12/1, there were 1,126 new resident cases in Michigan nursing homes. And for HFAs, with 80% of the facilities reporting, they did manage to experience a small decline in the cases during that same weekly period. However, we did notice that the AFCs sharply increased during this same time period. And as we have gathered more of the AFC data over time, we have attributed some of these earlier increases in caseload to increased reporting from AFCs, but that's not the case for the past week. In fact, reporting decreased from 75% to 72% over the last week, and yet we saw a very significant increase in the number of cases there. So this is a data table, and we recreated it from the same MDHHS reporting page for long-term care. We wanted to try to capture some of the information regarding staff cases without, increasing the number of graph slides that we have. So you can see that as of Tuesday, there have been a total over time of about 27,000 staff and resident cases in long-term care facilities over the course of the pandemic. And our totals are almost 3,500 deaths related to those settings. Yesterday, we took a look at the MySafe start map as we usually do, and we didn't look again this morning, so I'm not sure if they fixed it, but there seemed to be an error. The Lansing region, for some reason, had no designated risk level at all, although the individual counties there were identified at the E level still. So we think this is some sort of blip. The data, though, does confirm that brief decline in overall positivity rate, although that positivity rate is still quite high. And we also have seen a correlation as a decrease in new daily cases. So we're going to look at some of the recent MDHHS updates, and then we'll take some questions in a few minutes. So one of the most important directives, at least impactful directives, that we have received recently is a clarification from the department on visits to COVID positive persons. We had been receiving some conflicting information from some local health departments, but we had always known that in the October 21st guidance, it does clearly say that without exception, visits to COVID positive persons were prohibited. But because we were hearing different stories from the local health departments through our members, we contacted the department and with the idea that we did believe that at least end-of-life visits should be allowed for these persons. It did take them several days to respond, but they finally came back and said that there were no visits allowed for COVID positive persons. But they really didn't speak to the entire language and our entire question, because the original guidance also disallowed visits for persons who are under observation. And that would include persons newly admitted and without any symptoms. So technically that guidance precludes end-of-life visits for those persons as well. And that seems extremely burdensome to us. So they didn't really respond with clarifications about those persons, so we've asked them about that again, and we're still waiting for a response. The department also has put out a notice that care and recovery centers will not have to apply the 85% occupancy rule for cost reporting to those units, and that consideration will be extended to COVID relief facilities as well. It just occurred to me, I think that we have another slide on this later, but that was a recent update. It's not very complicated provision. And during the past week, the department has also put out a policy to encourage hospitals to develop swing bed units as COVID dedicated units. Hospitals can use the 1135 blanket waivers that will allow them to create swing beds across the state and avoid the current rules for when you can have a swing bed. And the criteria that they put out for these units pretty much aligns with the Care and Recovery Center requirements. But these are temporary. These will only last during the pandemic. On Monday evening, the department issued MSA 20-78, and that extended the application and implementation date, as Dalton suggested, for COVID relief facilities. And that date is now December 15th. So that gives members about 2 more weeks to work through some of the issues and determine whether or not to apply. There were just a few other changes in the guidance as well. They're really not very significant, but they now include that the facility must be licensed by law as a nursing home. That wasn't clearly stated before. And they added another option for providers who are applying to accept new admissions. Previously, they had to hold a 2-star rating in staffing, but now they will accept an overall 2-star rating as well as meeting the criteria. The department has also issued another update since last week for SNF reporting to EMResource. They've said that they have finally worked through the glitches in aligning with the new NHSN requirements. And there are additional elements that have to be completed in order to satisfy the CMS/CDC reporting regulations. The department can submit to NHSN at the CDC when the listed data fields, and we have the areas that those are in, are completed in full. And at this point, facilities no longer have to report to both entities. Apparently, they have cleaned up whatever the technical problems were with reporting to the CDC. They do remind members to verify their CCN number and their NHSN ID in the COVID long-term care supplies report. And that will ensure that MDHHS has the key information for accurate submission. The department has also sent out a reminder, I think this came out yesterday, that reporting for all entities, SNFs, HFAs, and AFCs, that reporting is due by noon today. They also note that HFAs and AFCs who have registered using Qualtrics must do their reporting today as well, and that those reporting dates are from November 25th through December 1st. So you're always reporting for a full week. HFAs and AFCs who have not yet reported, in other words, they have not yet registered to report, should contact the department at this point. Just as a note to our members, and I don't know that we have any members in this category, but the department's long-term care data webpage lists all the providers at this point as out of compliance if they've not yet registered for reporting. So just to let you all know that, there's a long list of AFCs and HFAs who are considered out of compliance here. There are a few outstanding department questions that we are waiting for responses for. Several members have asked whether or not during the staffing crisis, if they can use asymptomatic COVID positive staff as dedicated unit, COVID unit staff. We do know that this has been an approved crisis strategy recommended by CDC, but only in crisis times. And that's been in their guidance for a long time. Some hospitals have been doing this in Michigan, but they have gotten a lot of negative press about that. So we have reached out to see what the department's position is on this, and they have yet to respond. All of the issues on this page, they've not yet responded. One of the guidance pieces that the department put out recently was about HFA and AFC testing and CLIA waiver status. Apparently, except for certain circumstances, and being a not-for-profit is one of them, but except for certain circumstances, you need a separate CLIA waiver for each license. And although not-for-profits seem to be exempt, we do know that some members do hold a for-profit associated entity within a given TIN number. I'm not sure how that works, but we do know that some for-profit associated entities are not allowed to, in other words, they all have to have a separate CLIA waiver for each license. This was very confusing to us and some of our members, mostly because the application itself for a CLIA waiver doesn't ask for license information. It only asks for tax identification numbers. So we've reached out to the department about this to confirm whether or not the issue is, do you need a waiver per license or do you need a waiver per TIN, because the application doesn't even differentiate it by a license. Again, we're waiting to hear whether or not their expectation is that newly admitted persons under observations should be permitted end-of-life visits. And again, we've let the department know that disallowing end-of-life visits in this instance would be a huge family burden. Some questions have arisen about the MICR requirements for registration. That came out last week. There is a provider portion and a site portion to the registration process. However, the site portion specifically states that it's designated for sites who will actually be administering the vaccine. So we did get a response from the state, and they implied that all sites have to register if they're, participating, but they didn't clearly say whether or not it's required for facilities who are not administering the vaccine as part of the pharmacy partnership program. So this is a complicated process if you're not already using MICR. So we wanted to make sure that the facilities actually have to do this before they go through that. And we're waiting for some clarification then from the state. And last week, the department, in a meeting that we had with them, they were encouraging providers who know that they don't currently meet the criteria as a COVID relief facility to go ahead and apply anyway, so that the department understands that you have an intention to do that. However, that doesn't really work because the application itself will deny you up front if you don't meet some of the criteria, such as providing dedicated staff. So that idea is not working very well, and we've let them know that. So this is one of the more controversial rules that has been recently released, and that is a directive from the Division of EMS and Trauma. They have apparently had experiences where long-term care facilities, and they mean all of them, nursing homes, AFCs, HFAs, have called on them, have called on EMS to transport asymptomatic COVID-positive persons or persons with very few symptoms who really don't need acute care to the hospital, mostly because the facility, and this is more common in AFCs and HFAs, but some nursing homes as well, because they can't safely manage them. So in some of these instances, the hospital refused to admit or even see the resident. And in others, they did end up admitting the resident only because there was no safe discharge place because the facility refused to take them back. So the department feels this is a major problem for hospitals who are currently in the middle of a COVID surge. And they issued this directive to EMS providers that includes an alternate process for this. And in that process, the EMS provider assesses the resident and then consults with the medical control staff to determine whether or not a transport that is appropriate to transport this patient to an acute care setting. If together they decide not to transport, they will work with the patient and the facility, as it's written here, to determine an alternate plan. Well, this is a problem. We all know that there are limited options for these persons, so it's unclear how these alternate plans might work. And this is really another example that the state does not have a plan or a priority for residents in HFAs and AFCs. And these are the providers who are really least prepared to care for COVID-positive residents in general. And many of these residents can seem absolutely fine one day and very, very ill the next. So the other controversial piece of this new guidance is that the EMS director, during a meeting with MDHHS, identified that the guidance has the force of law. And I'm not sure what that statement was really about, because in the document itself, it encourages local authorities to adopt the guidance. So it doesn't even seem mandatory for local authorities to do that. So we are extremely concerned about this guidance, and along with the fact that the department has never really created a plan, a reasonable plan, or a plan really at all for consumers who need to be cared for who currently reside in HFAs and AFCs. So we are working actively with the Michigan Assisted Living Association, and we're going to communicate our concerns and advocate for better care planning for these persons in these environments. So we're working on that this week, and we'll certainly give you an update as things move forward. So let's take a break for some questions.
All right, thank you very much, Deanna. Before we get into any questions, each year, LeadingAge Michigan honors individuals and groups who embody excellence in leadership, care, and service innovation, and who have made outstanding contributions to their communities and within the field of long-term services and supports. It is always a time of acknowledgement, celebration, and laughter. This year especially, we point to those who have endured through this difficult time and managed to serve with grace throughout. Join us on Wednesday, December 9th for a free live streaming event at the LeadingAge Michigan Facebook page. Our event will be divided into two separate events in order to best accommodate our audience. Starting at 3 p.m. with a keynote presentation and a celebration of our Leadership Academy. Then we will reconvene at 7 p.m. and we will be hosting a celebration and recognition of our award winners for members, colleagues, friends, and family. This year, we will be virtually acknowledging our many award winners, and we will be joined by two of Michigan's greatest resources, Monica Levin and Tim Cusack. We are excited to be able to acknowledge our many award winners and celebrate one another as we all do our best during these very challenging times. LeadingAge Michigan would also like to thank our many dedicated business partners who continue to support our members, their staff, and the association in everything we do. So with that, we would like to thank you, Matthew Garlick at Omnicare. We'd like to thank Andy McLeod at GMB, Kim Murphy and Carrie Hensel at Therapy Management, Sheila Ralston over at Creative Dining, and of course, Tom Myers at Ziegler. Together with our sponsors, we know by working together and offering support to one another, we can overcome anything. So come and please celebrate one another with us. Registration / I would say RSVP is actually open for this event right now. So if you head over to the LeadingAge Michigan website, leadingagemi.org, you're going to see this banner right here. It's going to be the very first banner you'll see that will pop up. You can go ahead and click on that, and that will take you to our registration page. You can go ahead and register, and it is a free event. We just want to make sure we can get the link to you so you can go ahead and join us. Again, this will be December 9th, so we will not be hosting our Safe and Calm webinar next Wednesday, December 9th. Instead, please come and join us at our Serving with Grace event. So we do have a couple questions, so let me pull those up really quick. Okay. If a facility is eligible and approved today to be a CR facility, but their star rating goes down later, what happens to that approval?
I am not sure whether or not the state is going to be, how closely they're going to be monitoring that data over time. I don't remember this coming up in the past, so I don't know what the department's take on it. But I think that if your rating goes down in the future, you should probably communicate with the department. And we can ask that question to the department moving forward. I'm hoping, I don't know if this is really true, that a lot of, I mean, there are health inspections going on and staffing, but a lot of the star rating elements are frozen. So we don't anticipate a whole lot of change in star ratings, but we do know it's possible. We'll ask the department what their take on that is.
Our medical records department says they can't code COVID positive for residents done with BIMAX POC test. Said they require a lab slip / result to code in order to get the COVID-19 reimbursement. Has anyone else had this issue, and what are you doing?
I don't know if anyone else has had the issue. We can certainly put that out on the listserv unless someone, has some comments right now. I have not heard of this problem at all. So this is new to us. And if other members are having difficulties with this, you can let us know now, or we can put it out on the listserv.
How do we apply to be a COVID relief facility? Is there a direct link or a form to fill out?
There is an application, I believe it's in SurveyMonkey. We've sent it out several times. I will know who you are from your question, and we'll make sure that we get it to you today.
Dalton spoke of pending legislation regarding electronic monitoring of SNFs and HFAs. Monitoring of what to what end?
Dalton, go ahead.
Oh, okay. So right now, the only bill is for residents to have the right to install electronic monitoring equipment in their room. This would be with express permission from the resident and the resident's roommate, should they have one. The process itself is not defined in the bill. That would be defined by the department. But there are certain restrictions on that, and I do plan to do some of this on Friday. Go over it on Friday, since the bill is still kind of moving through the process, but it's facing a time crunch because it's kind of in the lower committee level of the House right now. So it would have to go through 2 committees and then pass the House and then be signed by the governor. And historically, the governor has been kind of on labor's side, and labor doesn't typically like these kind of a bill. Or like this kind of a bill. The HFA AFC bill would be very similar to the SNF bill, but that is not currently in the process. That just comes from conversations we had with the bill sponsor, who says this is what he'll be pursuing in the next legislative cycle, along with the SNF electronic monitoring package, if it doesn't pass this time around or before the time crunch comes up.
All right. Thank you to both Dalton and Deanna. It looks like that was the last question for now, so we can go ahead and move on.
So before we get to the recent department guidance on vaccinations, I've included in this section a brief update from the CDC on vaccinations, and this is, excuse me, particularly a list of things that they want to remind healthcare professionals about in terms of COVID vaccinations. So there are 2 vaccines in clinical trials, and there's one more on the way, getting near that right now. And one of the issues is that one of the vaccines will need ultra cold storage, and that can be a problem because you're talking about a very, very cold freezer, something like 70 degrees below zero or something. So the CDC and the states are working together to develop multiple plans based on which will be available first, whether or not you're going to need ultra cold storage or going to be able to administer. So they have multiple plans working with sites in Michigan to figure out how they're going to make this all happen very quickly. And they also want to make sure that people know that they're going to be tracking the administration of these vaccines. And that's partly one of the reasons why they have to be reported in MICR to monitor safety and any other issues that might arise. And however, the FDA has stated clearly that they're not going to release authorization for these vaccines until they have at least gone through some safety protocols as used in emergency situations. One of the things in this guidance is that CDC encourages health professionals to communicate a positive view of the vaccines. So there's a strong encouragement about that because they're obviously very much for vaccinating as many people as can be done, and especially vulnerable persons. This positive view is meant to include, some discussion with residents and patients that this is a necessary safety precaution. And they are encouraging staff to help build patient confidence in the vaccine. So we all know that only limited quantities will be available in December. Some are anticipating that by mid-December there will be some word from the FDA on emergency use approvals. Supplies will be increasing more rapidly in 2021. And they know that some groups will be prioritized. So in this guidance, they had not yet made their recommendations. We'll talk about the CDC recommendations about priorities in a minute. So following up at the state level, again, the department has recently issued information about the requirements for administering the vaccines. And we have noted in our outstanding questions to the department, that there's both a provider portion and a site portion. So we're still waiting to figure out who's going to be registering this in MICR. Our thinking is that if the facility where the resident resides, but who is not actually administering the drug, if they don't have to register, the pharmacies in the Pharmacy Partnership Program are already registered. So we're waiting for word about that, but we do know that everyone who receives the vaccine has to be reported in MICR some way. We have included the links for the online registration. Here, there's also some additional information about the CDC, the Michigan COVID vaccination plan as well. And yesterday, during the governor's press conference, Dr. Caldoun presented the plan for vaccinations as it currently exists in Michigan. Again, they're currently working with potential sites, and they mean hospitals and health departments mostly. Staff are probably going to get their vaccinations from health departments, and they're working on their entire distribution plan. We do know that the Pharmacy Partnership Program is going to take care of the majority of long-term care residents as we move forward. The two that are expected to be approved soon both have 95% effective rates so far, and these will require separate doses. Because there are limited quantities, Michigan has identified the following priority list. The first priority is meant to be ICU staff, direct hospital workers, EMS workers, ER staff, and then come care facility workers and residents of, they said skilled nursing facilities, but they didn't identify other kinds of facilities, but since residents in all long-term care facilities are going to be covered by the pharmacy partnership program, we don't believe that that's going to be an issue. Then we'll follow other healthcare workers and essential workers such as teachers, etc. And then finally the general public. And after Dr. Khaldun presented this yesterday afternoon, later the CDC voted to make healthcare professionals and long-term care residents the priority areas. So it seems that this guidance is in alignment pretty much with the CDC recommendation. But it is important to note here that the state has authority here, not the CDC. The CDC can only recommend. But we don't anticipate any difficulties. We believe that residents and staff in our facilities will be priority. This is an update for nursing homes, and basically it's not really COVID related, but we thought we would review it this morning. We anticipate there might be some questions coming about it. Members are probably aware that the state had planned to change its reimbursement system by October 1, 2020, but that had been placed on hold, thank goodness, during this COVID crisis. And in order to study, for the state to study how to apply a person-centered process in determining their rates, a process that would be similar to that used in PDPM, they need to review MDS information from each facility. And they're going to continue to need that information when they move to a new reimbursement system as well. So the state has identified the specific areas of MDS that they need information about. And that's pretty much the entire PDPM set, along with a few Section GG and other elements. But this should not really impact providers much as long as you're completing your MDSs on a timely basis, because it's our belief that in this process, CMS will simply turn around and provide the data back to the state. There is no direct action that a nursing home should have to do. We're going to wait to get confirmation about that because it wasn't really stated in the guidance when it came out, but we are fully aware that other states that do this, they simply get the data, the state gets the data back from CMS. So it shouldn't be anything additional on the nursing home's part right now. So the department also issued updated guidance on care and recovery centers. Those units, and I spoke about this a little earlier, they'll be exempt from the 85% occupancy rule. And they are extending this to COVID relief facilities as well. And they anticipate some additional information will be forthcoming about how to adjust your cost reports. And there are avenues here for both questions and comments that can go back to the state. And the document, the link for the document is at the bottom of the slide. LeadingAge. LeadingAge has put out information on a number of tools and resources for members. There is a webinar on provider relief funds this afternoon. They have a testing toolkit. A lot of these are not new, but we just wanted to remind members. There's a testing toolkit, includes some draft policies, standards of care, etc. There's information on how to access and participate in the ECHO network. And lastly, they've also developed a pandemic playbook, and that includes a lot of shared stories, a lot of shared and best practices, etc., that some members might find helpful. This past week, we developed a guide that we think includes a lot more information and is a tad more clear, at least, than the department's infographic on visitation. I do want to let everyone know that the copy that we sent yesterday to members was erroneously labeled for HFAs and AFCs. This is a set of rules that applies to nursing homes, HFAs and AFCs as well, because the rules are the same for all these settings. So this really applies to all of those. We're not going to go through each of the provisions. They align with the visitation guidance, but we tried to create a little bit more options, the type of visits than the department did. And hopefully this will help people when they're not sure whether or not a visit of some sort is allowed. We do know that, since most of the counties are in level E, their visitation is extremely restricted right now. But we hope this helps you. And if you have questions or comments about this, please email me. We will work through it. And if you have any ideas about how to improve it, we'll certainly take that as well. The CDC during the past week issued a guidance for care of persons who may have both influenza and COVID. And they also focus on the fact that when someone first develops respiratory symptoms, you really have no way of knowing whether or not they have either or both of these conditions. So they recommend placing anyone with respiratory symptoms immediately into transmission-based precaution. But of course, you should not move anyone to a COVID unit until you have a positive test result. You can move someone with respiratory symptoms into a private room and isolate. And if you're using antigen point of care testing, you should know right away whether or not you have a potential positive person. But if you have symptoms, you're going to treat them as positive anyway until you do a confirmatory test. Note that a negative antigen test for someone with symptoms needs to be confirmed. So again, until you have a positive test, though, you can move them to a private room and isolate them. They also suggest that during this flu season, that any person with respiratory symptoms should be tested for both influenza and COVID. And both should be considered as possible conditions for anyone with these symptoms. A positive COVID test does not mean that they will not have influenza. So just because you might take a COVID test first and it's positive, it doesn't mean they have influenza. So you should actually use both tests on anyone who has symptoms. The CDC also reminds facilities that they must notify the health department for any suspected cases or confirmed cases for both COVID, either or, COVID, influenza, or both. And facilities are required to report persons who have had a severe respiratory infection that has resulted in a hospitalization or a death. Those have to be reported. And this is another reminder, we haven't talked about it in a long time, but you are required to report whenever 3 or more residents or staff together have new onset respiratory symptoms within a 3-day period, 72-hour period. Again, they suggest testing for both, and they note that some collection methods might differ for one test or the other, depending on the kind of test that you're using. An example of that is a saliva test. Often works for COVID, but it will not work for influenza. So if you're testing for both, you have to make sure you have the right specimen collection plan for the test that you're using. And if both tests end up negative for someone with symptoms, you should move on to check for other respiratory pathogens as well. Another issue is isolation. If you do identify people and they anticipate you're going to have people who have both COVID and influenza at times in the near future, If you can't isolate a person with both of those diagnoses from those persons with just COVID, you need to let the health department know that, because it's important to try to avoid infecting COVID positive persons with influenza. That's just going to make their course and recovery much more difficult. So you need to try and separate those persons. And if you can't do so, you need to let the local health department know immediately and work through some planning. Persons with influenza alone can be cared for in a single room. You know, you don't have to have a dedicated unit for influenza alone, although you can cohort them with other persons if you have others in your facility who have influenza and not COVID. If necessary, to keep them in a double room, in other words, if you don't have a private room for an influenza resident and you can't cohort, you can try to create a barrier between the residents. That's the next best option that the CDC has identified. And for influenza only, and this was new to me, but remember, I'm not an infection control and I haven't been a direct care nurse in years and years and years. But you must use droplet precautions with eye protection for influenza on top of standard precautions. And I did not realize, I don't know if that's new, but the eye protection piece is something that is directly in their recommendation. And lastly, of course, they encourage vaccines for influenza and for COVID for residents and staff when they're available. Additionally, this week, the FDA included an update to its page on face mask use. This was a voluminous web page with numerous links, a lot of information, and we've included the topics for those, the content on that page there. So there's a lot of detail here, and we couldn't identify where the new information was, to be honest. So we want to make sure that you're aware of this. If you have questions and issues about use of face masks, respirators, and surgical masks, that you review this. We do know that there's a lot of questions about PPE sometimes. So if there is member interest, we can focus on this and review it with you in the future, but I want to make sure that you want to do that and you have a need to do that. So please let me know. There's a lot of information here. We can go through it with you, but it would take probably most of an hour at least. So let us know if there's interest. We will include this in an upcoming webinar. And last on our agenda today is a notice from the Long-Term Care Ombudsman Office on a grant program that they've developed, and they received a grant from the Aging and Adult Services Agency. So right now, this grant is for nursing homes, and they're focusing on nursing homes, but they might consider homes for the aged as well. They can apply as well if they don't get many applicants from nursing homes. So this program provides an animatronic animal to assist seniors who are suffering from loneliness and isolation. The application, which is linked here, should be submitted by December 4. And there's also a brief webinar and on YouTube that you can review, and there is a information page as well to look at this pet adoption program, they're calling it. So anyway, the links are there for anyone who is interested in applying. So with that, we can move on, see if there's any questions.
All right, thank you very much, Deanna. We do have just a couple questions, so I'll just jump right into those. Would LeadingAge Michigan consider polling members to see if or how many are considering mandating that their employees get the COVID-19 vaccine when it becomes available, and what their concerns might be regarding mandating the vaccine?
Sure, we can do that. we can do that. I know that mandatory vaccines has always been somewhat of a controversial subject. I do know that some members have done it and others do not. So we can certainly follow up on that.
Where do you see senior living workers, residents in the vaccine program?
Can you say that again, Blake?
Where do you see senior living workers and residents in the vaccine program?
So senior living, I guess I need to know what senior living means. If you're talking about congregate settings that are not perhaps licensed, they're not specified, but I would think that there is a, I think they said care center staff somewhere. And I think the seniors would be one of the more vulnerable populations.
She said
they would not be first on the list.
I was just going to say.
Sorry?
She said independent living, assisted living.
Okay. So I think that they don't occur first on the list, that's for sure, because those are going to be hospital workers. I would assume that they would occur somewhere in level 2, maybe level 3. But we can clarify from the department because one of the things that struck me during the governor's press conference yesterday was that Khaldoun actually talked about nursing home residents in the second tier, but she didn't talk about any other areas. And so I do believe that that piece will be covered by the pharmacy partnership program. And I could be wrong, but I think that there are other settings other than licensed settings. I'm not sure about this. I'll have to check back. I'm not sure where you fall in place for the pharmacy partnership program, so we'll have to investigate that. And we can certainly ask the department how that will play out. There is a very long MDHHS vaccination plan guide. I didn't see clear priorities in it when I briefly looked at it yesterday. So I think that this is something that hasn't been clarified by the state, and we can ask them.
How should we handle consent and orders for POC testing? If we already have orders and consent for PCR testing, does this cover POC?
I'm not sure that if you have an order for a test, if the type of test and the mode of test has to be included in the order at all. So I would think of order for a PCR test, but if the order specifies a PCR test, I think that you probably have to get another order. But also remember that there's currently guidance isn't the right word, but an exception to the normal rules for ordering lab tests that any healthcare professional pretty much in Michigan can order those lab tests. So, you know, an LPN can order those lab tests, an RN can order those lab tests. You don't need a physician or even a nurse practitioner to do that. So I would think that if your test specifies PCR, you probably have to get another order. If it simply specifies a COVID test, I think you're probably safe. This question has not come up before.
Has the sorry, one second, it scrolled away. Has the decision been made regarding vaccination for prior positive COVID people?
No, I have not seen anything about that. I would think that that doesn't mean that it's not out there, because remember, I don't read absolutely everything in the world, but I've not seen anything about that yet. I would think that perhaps for a short time, a vaccination would not be required, but I would think that at some point, considering that there have been reinfections, at least a few, that those persons should be vaccinated as well. That's a good question, and I think that we can put that out to the CDC. It takes a week or two to get a response from the CDC. They're not as quick as everybody else, but they generally do respond.
Are the majority of people applying to be COVID relief facilities just to retain their own people resulted in additional survey visit, or are they doing this virtually?
Say the second part again, please, Blake.
Are the majority of people applying to be COVID relief facilities just to retain their own people resulted in additional surveys visits, or are they doing this virtually?
Okay, so the majority of facilities that have applied so far, and there's been several hundred, are to retain their own residents and not necessarily to admit. So I think it's maybe a 2-to-1 margin right now. And of course, not all facilities have applied for anything, but of those that have applied, about twice as many as are asking to be a retaining facility only, and another that's probably twice as many as those who want to admit. My understanding is that if you are retaining only, you will likely have a virtual visit. If you are want to retain and admit, you might have an on-site visit. If you're asking whether or not those visits are taking place, my understanding is that some of them are, but I don't have any information from members about how that's going or any further information about that at this point.
Okay. If symptomatic resident tests positive with POC, you should place them in an observation unit until the PCR confirms, then place them in a COVID relief unit.
Unless you suspect that you might have a false positive, I think that they need to go into the COVID unit. This issue has come up a couple times. There are false positives, but I'm leery about assuming that you might have a false positive unless you have a lot of information that makes you think that the likelihood of this person being positive is small. I will check into what the guidance says. To me, if you have a positive antigen test, you have a positive antigen test. There's no reason to confirm it. If you are in an area of high transmission, if you have an outbreak in your facility, and pretty much the entire state is in an area of high transmission, there's no reason that you have to confirm it at all. If you go back to the CDC guidance, there is no confirmation required for that. The only time you do confirmatory testing is pretty much if you doubt the finding. And if you doubt the finding, then yes, I would not move that person right away until you confirm positive or negative. But there's no confirmatory test needed for anyone with symptoms, anyone in a high transmission area, and specifically if you have an outbreak occurring in your facility. Those persons need to be considered positive and moved to a COVID unit.
Do the CRFs retain own residents, only address SNF residents, and therefore AL and IL residents in our communities would be considered outside admits?
If you're on the same campus, the department has come back and said you can consider those retaining. So if you have someone independent living on the same campus, you can consider a move, a COVID positive move to your skilled nursing facility or even your assisted living facility as a retaining resident.
Okay. My understanding is that a positive POC antigen is a positive, even with a negative PCR, especially during an outbreak, which makes all positives positive.
Yes, that's my understanding as well, although I have had a couple of scenarios given to me by members where they really doubted the positive test I'm very, very reluctant to call something a false positive. And I believe that most guidance does imply that you should treat them as positive even if you have a PCR negative. So that's my understanding as well. There have been a couple small exceptions to that. But again, as long as you're in an area of high transmission, you have an outbreak in your facility, it doesn't matter whether that PCR test is negative. Number one, sometimes it's the timing of that test in terms of viral load, and there are PCR false negatives and false positives as well. So you've got to remember that you're dealing with a system that is not 100% accurate all the time on both sides. But a positive test is much more likely. I think it's up to 90% likely. If you have a positive POC test and you're in an area of high transmission or the person has symptoms, the chances of it being accurate is something above 90%. And I would treat them that way all the time. But again, I have to say, there have been a couple exceptions, and you've got to look at it on a case-by-case basis. But in general, you're correct, and I 100% agree with you.
For COVID retain, are residents on sister campuses able to be moved to skilled nursing on another campus?
No, you have to be on the same campus. That's part of the idea, is that there's a shared environment in some way, and sometimes shared staff. There's a sharing on that campus. The department was pretty clear about the fact that they have to be on the same campus in order to be considered retaining only.
Okay, I don't know if this is a similar question, but I'm still going to ask it. If retaining a resident from the campus that tests positive, can we accept them after they have gone to the hospital, or is it just internal transfers?
No, you can. They are considered a retaining person from your campus back to your campus as well. So a new admission is someone who has not been on your campus and of course is coming in with COVID.
Okay, as of right now, it looks like that was our last question. So if you do think of anything after this webinar has concluded, as always, you can fire off an email to Dalton, Deanna, or safeandcalm@leadingagemi.org, and we will make sure to get that answered for you as soon as we can. So at this point, we would like to say thank you to Dalton and Deanna, and we would also like to thank our 100 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. As always, we will be here on Friday for our next Safe and Calm call, this Friday at 11 a.m. Eastern Standard Time. And just a quick reminder that we will not be holding our Safe and Calm call next Wednesday, December 9th. So feel free to come and join us at our Serving with Grace event on the LeadingAge Michigan Facebook page. Other than that, I hope everyone has a great remainder of their Wednesday, and we will see you guys all on Friday. Thank you.
Take care, everyone.
Take care.